Cool.
All right, I heard the robot voice, which tells us we are going. We are being recorded. So welcome, everyone. Thank you all so much for being here. My name is Alex Sorotsky. I'm with the Washington Poison Center. I've got just a really quick intro to go through today, some housekeeping before I turn it over to our wonderful speaker. So I put this in the chat box. Well, I was about to say I put this in the chat box on how to turn on the audio, but you wouldn't be able to hear me if your audio was off. So if you got a friend who's struggling with audio, tell them to look in the chat box for instructions there. All right, folks. So slides will be available when we post our materials to the Poison Center website. That'll be in a bit of time. So don't worry if you can't find them now, we'll get them to you. Like I said, all sessions are being recorded. Those recordings we will post to Whova, this platform now, hopefully by early next week, and then eventually we'll get those up on our website as well. Now, we do not have CEs for this year's series. However, if you watch at least 5 sessions, whether they're live or recorded, by September 15th, we can get you a certificate of attendance, at least. And again, that's 5 sessions by September 15th to get that. I feel like I'm in an infomercial. 5 now by this date, and we'll get a discount. All right, so we're also going to be sending a survey out at the end of the series. We just love to get feedback from as many of you as possible on how you felt this year's went, and helps us generate ideas for next year. And finally, for any questions you have, please reach out at any point. If you've got a comment, go ahead and put that in the chat box. If you've got a question, go ahead and put that in the Q&A box. I'll be fielding those as we go. All right, so I am very thrilled to introduce Dr. Adam Taniguchi, and Adam is a PGY1 community pharmacy resident at Kelly Ross Pharmacy Group. He is a recent graduate from the University of Washington School of Pharmacy. All right, Dr. Taniguchi, it is all yours. Take it away.
All right. Thank you so much, Alex. Appreciate it. Just going to share my screen here. All right. Well, once again, my name's Adam Taniguchi, and that was a great introduction. I appreciate it. Just am excited to be here. Happy to be a part of the 4th annual overdose prevention, harm reduction, and treatment services. The presentation today is going to be naloxone in the community. So being a pharmacist, I just kind of want to focus on how we could really access naloxone, and also just some administration of naloxone and some common questions that we experience. So here again, is this an outline of what we'll talk about? So just have some statistics about overdose, Washington State specifically, then some national data, and then again, availability of naloxone in the community. We'll go over the administration, and then I have some common FAQs at the end. So we kind of covered it with the introduction, but just wanted to kind of talk about myself a little bit. Like I said, I was a recent graduate from the University of Washington School of Pharmacy. Just got my license, passed my licensure exam, so really excited to be here and be a resident with Kelly Ross. You know, we're really trying to make a good impact with the community, and happy to be a part of it. And it's kind of a unique setting because Kelly Ross does partner with a Laced and Lethal program. So this is a partnership with the Department of Health and King County, where we are dispensing naloxone kits through the mail. We'll talk about this program more when we're further down on the presentation. However, just wanted to set the stage a little bit, kind of show some cool stuff we're doing here with Kelly Ross. There's 2 lines here. First one, received kits per month. This data is from July last year through June of this year. So it's approximately about 12 months worth of data. I was happy to talk to Robin at the Department of Health, and she was able to get me some of this, along with Chris, who works here at Kelly Ross as well. And we're able to crunch some of these numbers. So thank you to those if you guys are here or watching this in the future. But we can see the kits per month here on this bottom line. And then we could see our total amount of kits that we have then kind of totaled throughout the last year. So really exciting. We have mailed out 21,560 kits of naloxone. So hopefully, definitely preventing some overdoses and helping out with the community. So next, I just want to talk about some of the statistics within our state, some national data, kind of some trends that we are seeing. So this first chart graph here depicts Washington State. This is from the Department of Health. This is by county, and it is showing the rate per 100,000 population of opioid deaths. I did confirm, kind of formulated this so each county is then not with an all drug rate, but this is specifically to opioid overdose deaths. With that, we did see in 2022, 2,045 opioid overdose deaths. If we then kind of look a step higher and look at any drug overdose, we do see 2,698 deaths in Washington state. So unfortunately, this is an upward trend we're seeing, and definitely some work we need to do or try to spread some word. And hopefully with this presentation or just in general, so getting naloxone out there in people's hands, carrying it, hopefully can help prevent some of these. Just some additional data points that I have. In Washington state, 39% of overdoses were excuse me, injury deaths in Washington state. Of all the injury deaths, 39% were overdoses. Of 9% of all injuries and hospitalizations were from non-fatal overdoses. There was 2,516, and 8% of all EMS, so emergency medical services, were responsive to suspected opioid overdoses. There was that is 7,234. So this next chart here, we're looking at graph. We are looking at kind of a timeline from 2000 to 2020. We're looking at, unfortunately, the increasing trend of overdose deaths. And then we could extrapolate a little bit more data here by looking by this top line is any drug overdose. So we're seeing an increasing over the 20-year period. And it actually has maxed out here at 22.5 drug overdose deaths. And then this line here is when we're then looking at opioids. So here in 2020, we had opioid overdose that was at a rate of 15.8 per 100,000 population. So unfortunately, we're seeing this increase. But one of the interesting aspects and one of the things we're really focusing on more now is this yellow line here, which is the synthetic, not methadone, which essentially fentanyl. And we're seeing a lot of that kind of get put into some of our street drugs. It's illicit manufacturing of it, and is, seeing a steep increase of these overdoses and deaths. Unfortunate. So just to kind of push on with some more of that data where we're starting to see that increase, we kind of break it down into three waves. First wave we see of some of these opioid overdose deaths was in the 1990s. This was really began the prescribing of opioids. And we had seen it kind of increasing since the 90s all the way up to 2010, when we see a rise in heroin overdose deaths. And then as we're progressing on through the time frame, we have this wave 3, which is the rise of synthetic opioid overdose deaths. We're saying it started about 2013, and this is when we're really seeing like fentanyl, the illicitly manufactured fentanyl, really coming out onto the market and causing a lot of these overdose deaths. And we can see the steep spike that we have now seen here in the last few years. And one thing with fentanyl, what I like to talk about is, it's much more potent. It's a very strong opioid. It's 50 times stronger than heroin. We could say it's about 80, 100% times stronger than morphine. Because of this extreme potency, and it's really cheap to make, we're seeing it really, it's an addictive, and we're really seeing it put into these street drugs and pills, powders, to try to help really stem some more addiction to this product, and it's become much more dangerous. And just some additional national data. From 2020 to 2021, opioid involved death rates increased over 15%. We saw prescription opioid death rates stay about the same, and we actually saw a decrease in heroin involved death rates. But we did see a 22% increase with synthetic opioids. So again, we're kind of seeing this trend here where we're seeing the synthetic opioids really take off over the last few years. So a lot of bad news there. We're seeing some overdoses rise. So what we want to focus on now is how can we access a life-saving measure? Naloxone, right? It is a reversal agent. It's a opioid antagonist. So it'll just displace the overdose drug in our system, displace it with naloxone, and we'll really see some good benefits. Hopefully, start breathing again. We'll talk about this a little bit more, but the one thing I really want to focus on is how can we get access to naloxone? So I put here 5 ways we can look at it. One is a prescription. That was our standard way of getting it. 2, there's a standing order here in Washington. We'll go over what that means and how we can access the naloxone kits. 3 is the new changes over the counter. It's been recently approved, and we'll go over some of this information. 4, there are some milk programs highlighted laced and lethal earlier. That's for King County, but we'll talk about that some more. And then 5 here is a website, Washington State Naloxone Finder, part of stopoverdose.org, very helpful, and we'll talk about that as well. So first, we'll talk about is prescriptions. This was the only way to get naloxone prior to it being approved as, and then this was the only way to get it prior to the standing order. This was the Narcan, or the naloxone nasal spray, was approved in 2015. It's still a viable option. The only hiccup is we have to go to 2 different medical providers to go and get this through a prescription. You have to go see somebody to prescribe it to you, and then you would have to go to the pharmacy to go fill this prescription. So with the opioid epidemic, seeing a rise of these opioid overdoses, we then tried to come up with a better plan, and that's where we came up with the standing order. I would mention, though, we still do see this in the pharmacy. When doctors are prescribing opioids, if it's a very high dose, we will continue to see patients being prescribed this medication. Or if we consider somebody is at high risk and using opioids, this is another person we might prescribe the product to. As far as high-risk patients, we're looking at history of maybe misuse of RX opioids, use of other illicit drugs, maybe some concurrent use of other medications like benzodiazepines, which could increase our risk for CNS depression, which is our big issue with opioids. We stop breathing. Or maybe a mental health disorder. So definitely have some telltale signs where we might see some doctors still prescribe this medication. So as far as the standing order, so in Washington State in 2019, we signed a standing order. So any person could walk into a pharmacy, so they don't have to go to the doctor to get a prescription and ask for naloxone. And the pharmacist can prescribe this medication for you. It's really cutting out the middleman, so it's making this drug a lot more accessible to patients and people who need it. So on the standing order with the state, there are 2 ways that it can be prescribed. You could get 2 1 ml single dose vials. So here you could get the vial for injection. And along with that prescription, you are also able to get then syringes and needles needed for it. They do limit to a max of 10 vials on this standing order. And then if you get the naloxone nasal spray, you could get 1 kit with up to a max of 5 on this standing order. So each is essentially 10 doses. And it's an easy way to try and get naloxone in your hands. I would say I have seen some issues with this. I actually read an interesting article in the Seattle Times. It was written by Elise Takahama. If you guys could look it up, I would suggest to read. It's pretty short. It was shared to me by a pharmacist here at Kelly Ross. Um, but they're discussing some issues patients have had trying to get naloxone from the standing order. One, there was distribution policies within the pharmacies, the big chains that they were going to, where they were limiting to the amount patients had access to, and the other was cost. Um, some were having issues billing insurance, some were covering it for copay when patients were expecting it to be free. So that's a tough landscape to navigate. I would say it's always dependent on your insurance if you have it. If you do have insurance with the state, so that is Apple Health, it will be covered and be free. So if you do have Apple Health, you can walk into a pharmacy and ask for it. They'll be able to give that to you, no of charge, free of charge. Just know it's not just walk in and they hand it to you. You will have to go through whatever standard wait time there is at a pharmacy, maybe fill out some paperwork if you're establishing a new relationship with that pharmacy. And but yes, it's a very, very good option here in Washington State. I'm glad that we have it. So the new over-the-counter naloxones were just recently approved by the FDA. There's two versions that have been approved. We have the 4 milligram, which is Narcan, the brand name. That is made by Emergent Biosolutions. This was approved for the over-the-counter sale in March 2023. And just last month, a new product was approved by the FDA for over-the-counter use. It's a 3 milligram nasal spray called Revive. And this is manufactured by Harm Reduction Therapeutics. So I don't know if anybody's out there has seen it. I would love it if you could throw it in the chat. I haven't been able to see it over the counter yet. I've tried to order it through our pharmacy wholesaler, and it's always saying not available yet. So I'm assuming nobody's seen it, but if anybody's been able to find it over the counter, please speak up. Let me know where you found it. That'd be great information. But when I was looking up kind of the availability, which is the issue where it's like, okay, this was approved back in March. Where is it at? The Narcan manufacturer, Emergent Biosolutions, said they had to create new packaging to meet the standards for over-the-counter packaging, and it was going to take a little bit of time. So they were expecting it to be ready by the end of summer 2023. And at least here in Seattle today, it definitely feels like summer is gone. So I'm like, oh, maybe it should be here, but unfortunately, still not there. So I'm just thinking they're still having a little bit of manufacturing or production issues. And then as far as this other new product that was disapproved last month called Revive, the manufacturer is stating that they're hoping for it to hit the market in early 2024. As far as cost goes with these, Narcan over the counters, the manufacturer states should be less than $50. That's fine, but the issue with over the counter is will it be covered, but you won't really have insurance coverage, so it's going to be out of pocket costs. And then another possibility, which I foresee, which might be an issue, if we have private or commercial insurance, I don't know how formularies will work where they will cover Narcan anymore because it's available over the counter. For an example, if you try to purchase ibuprofen that's over the counter in a pharmacy with a prescription, your insurance might say, oh, this is not covered because you get us by Advil over the counter. So we'll see how this works as we develop this landscape of the over the counter, but we'll see how it goes. As far as cost goes for this newer product, the harm reduction therapeutics, they state it will be free or as the lowest cost possible. On some press releases I read from them, they are saying it costs them about $36 to manufacture. So hopefully, and they're saying they're a nonprofit organization, so they're not trying, they just need to charge enough to cover the manufacture of this product. So we'll see where that lands. They also did plan to get out 100,000 kits for free to the people who most need it. So we'll look forward to that again at the beginning of 2024. So the last way to access naloxone is through some mail programs. I was mentioning less than lethal earlier. This program, unfortunately, is for King County residents. And I would say too, we should leave this program for people without insurance or cannot easily access this naloxone in the community. It is a free naloxone kit mailed to you. However, if we do have insurance or state insurance, we could kind of just walk to hopefully a close by pharmacy that has it and use them as a resource, and we could really kind of save some of these for the people who really need it or cannot afford it. But with that being said, it's still a great option if you're maybe in a rural area and you can't really have a pharmacy nearby to go to and use a standing order option. Looks like we might have a question here.
Yeah, I think this is a good time to bring this one up. Someone asked, actually from before the session even started, how do you help, or excuse me, how do you help get naloxone to people in your community when there is a stigma about being a drug user? So kind of a big question, but this seemed to be the space to address it.
So, I mean, stigma is going to be there. I think we all, just the fact that we're here talking about it is a sign that we're trying to go past the stigma and realize we're just trying to help people. Um, for me, to get people to get naloxone, I just ask. And then I give them these options to get it in the pharmacy. Anytime I dispense a prescription that has an opioid prescription, I will say, hey, you know, this product has a chance of having some severe consequences. Have you ever talked about using naloxone with this? And then we'll go through the spiel and we'll talk about, not just for the patient themselves, but if anybody else happens to get their hands on it or take it. And then I think Least and Lethal is a great program because this actually was initially started to encompass all age groups to try to give them a way where it could be accessed without stigma. You could fill out a form online, it'll get mailed to you. But I hope I'm trying to answer the question. It's kind of a big one, but I would say open communication is the best way to do it. I don't know how else to really say, but you know, let them know it could save your life. If you're using drugs, keep it on you and it could save you or somebody else's life.
Perfect. Thank you, Dr.
Yeah,
Taniguchi.
thank you.
I agree with what you were saying, and it just seems like to me the more we talk about it, the more we normalize talking about it.
Exactly. And about like kind of talking points or information, both of these websites, Stop Overdose and Laced and Lethal, are great options. There's great resources there just to learn, maybe see what's going on. Professionals, patients, people who are just curious about the subject. There's information for all levels, so it's really, really good options here. I would say, just as far as the mail programs go, again, the stopoverdose.org has links for Washington residents outside of King County. So that is a way where you could also try to get something mailed to you. It just has a link and you just fill out the form and it should be on its way. The other great resource I like there is Naloxone Finder. So all you have to do, put in your zip code and you put a mile radius and it pops up all the locations around that you could find naloxone at. And of course, knowing that naloxone is also available with the standing order we discussed. If you have a local pharmacy, community pharmacy, just a couple blocks away, that should be a great resource for you as well. So now that we kind of discussed some ways that we can find or access naloxone, I just kind of wanted to go over some administration tips or how to administer. So 5 essential steps. This is taken from the SAMHSA first responders 5 essential steps to take. So I think it kind of aligned with the way I would agree with kind of handling a situation. So first is evaluate for signs of an opioid overdose. Two, call 911. Three, we administer naloxone. Four, support the person's breathing. Five, monitor the person's response. With even within these steps, it's always good to have a plan. So I think if we're talking about the stigma question again, just talking to people who are using drugs or at risk of an overdose, just having a plan and having that open discussion is a great way. Keep a supply of naloxone on hand. Avoid using this on your own. Know your dose if you are using. Avoid mixing concurrent drugs that can increase your risk of an overdose. So step one, check for signs of an opioid overdose. An opioid overdose can result in death. So it's very important we kind of recognize some of these signs and symptoms. And like we said, opioids affect our central nervous system, and there's certain centers that control our breathing. So if we get too high of a dose of this opioid, it will stop our breathing, and that's where the naloxone will come in and displace that, and hopefully we can start breathing again. So one of the very big signs, breathing is very slow or stopped. If we're not breathing or breathing very minimally, we could turn pale, clammy to the touch, kind of be a bluish or purple cast in our fingertips, maybe kind of grayer with the skin. The body will be limp. The patient is vomiting or making gurgling noises. He or she cannot be awakened from sleep or is unable to speak. And heartbeat is very slow or stopped. So that it's kind of a crucial thing too. So if we're able to monitor heart rate, if we're able to check for a pulse, we could kind of determine also if we want to do chest compressions or not. But we'll talk about that coming up here. So if we're checking for signs and our somebody is not alert, what are we going to do? We want to do some stimulations. We want to kind of shake them on the shoulders, confirm who they are, shout at them, use their name if you know it. Maybe then the other one is the sternal rub. So our sternum or our breastbone, we just take the knuckles here and rub it on the chest. If you just do that yourself, it's uncomfortable. Just doing that to myself right now does not feel good. So we will definitely be able to see if we could somebody is going to be responsive or not. Step two, we call 911. Or if you're with multiple people, you could always designate somebody to call 911. What we learned in CPR training, you never just say somebody call 911. You always wanted to look at somebody and direct that one person to call 911. So that way there's not that kind of bystander lag response where it's like, oh, somebody else will do it. And then when we do call 911, we always want to just say somebody's not breathing. This is going to kind of bump them up on the priority scale and that'll try to ensure that we're getting emergency services to our location as quickly as possible. And again, we just want to make sure that we give a clear address or clear description of where we are at. Step three is administer naloxone. I actually have mine here as well. I did get this from a standing order, so that was pretty cool. So remove it from the package if you do have a package. And then we're going to hold the product here between our two fingers and our thumb. Sorry, it's kind of hard with the blurred screen. There we go. And then with the person lying down, we will tilt the head back, support the neck, and then we will insert the into the nostril, one side, and then you will press this red plunger down, or whatever color plunger it is, firmly until it is pressed. And that naloxone dose is then delivered. While we're waiting to monitor the patient's response, we always want to put them in the recovery position. So the main point with the recovery position, we want to keep their airway clear and open, just basically ensuring that no vomit or fluid does not stay in their mouth and they don't aspirate. So you can see here with the recovery position, we have hands to support their their head. So we kind of think of it this way, and this arm could be out as they're laying down. And then they have this knee down here to prevent them from rolling on their stomach. So when we're administering the naloxone, the response will generally recur in 2 to 3 minutes. So we want to give it that time to work, but then be paying attention because we might need to administer another dose. And this is important because the effects of and the duration of naloxone is pretty short half-life, meaning it doesn't last in our body too long. It's going to last about 30 to 90 minutes. So we just want to make sure that we're observing them for this time frame, or they are getting the medical treatment, going to the emergency department like they should because after this time frame, if they're not giving another dose, they could slip back into this overdose kind of situation. So step 4, I would preface this with, you know, depending on your safety or how comfortable you feel. If you're just innocent bystander, good Samaritan, happen to see this on the streets, depending on how the situation is, you might not feel comfortable. But if it was like my friend overdosing, I would definitely want to support the breathing. So I would leave that to you to think about and or carry a guard for mouth to mouth for breathing resuscitation. Is a good thing to carry as well. But we want to be sure that the airway is clear. We want to check the mouth, make sure there's nothing inside, make sure there's nothing in the throat blocking the airway. Then we want to tilt the head back, pinch the nose, and with the person's chin, tilt the head back and pinch the nose closed. Place your mouth over the person's mouth and make a seal and give 2 slow breaths. And we want to do this every 5 seconds. And it's important to think about it too when we're looking at this. We want to see a slight raise and fall of the chest, but not so much in the stomach. That means we might be blowing in a little bit too hard or forcefully, and we don't want to get it into the stomach. We want to make sure we're getting it into the lungs. And again, with naloxone acting pretty quickly, hopefully once we're administering this medication, they will return back to breathing on their own, spontaneous breathing. So that's again why we would want to monitor the patient, make sure they're continuing to breathe on their own, or if they don't fall back out, and we might have to administer another dose. We want to comfort the person being treated if they're coming out and waking up. A withdrawal can be triggered by naloxone. We'll talk about this a little bit more with some of the FAQ section. But as a result, some people might become agitated, but we could help them remain calm and just be there to be a comfort for them. But generally, most people are disoriented and confused, not necessarily combative. And then, like I was mentioning earlier, it's essential that the person goes to the emergency department. Like we said, the naloxone does not last very long. And once that wears off, the opioids can last longer in our system, and that patient could be at risk of overdosing again. So we want to make sure they're getting proper treatment, more doses if needed, and the supportive care that they do need. So the next section, I just wanted to address some frequently asked questions. Some I've come in practice with some friends, some with working in the pharmacy. And if there's more, I'd be happy to ask them. But the first one is it harmful if I'm not overdosing? Basically, is naloxone a safe product? And yes, it is very safe. But to answer the question, no, it is not harmful. There's minimal risks with naloxone. Basically, the only thing that we think about is an allergic reaction, but that would be pretty rare to see. Basically, if it's used by a person not using an opiate, it might at worst make them feel a little uncomfortable, especially for doing the nasal administration. Maybe you feel a little stuffy, maybe a headache, but very safe to use. I would say too, with pregnancy, if somebody is in risk of is having an overdose and is pregnant, it is okay to use. We want to try to save them at that point. Um, so don't let that be deterrent if an opioid is overdose is suspected during pregnancy. Would like to add, uh, we're talking about naloxone and opioids, but this does not work on other drugs like cocaine, methamphetamine, alcohol, or benzodiazepines. So benzodiazepines are like your Xanax, alprazolam, diazepam, Valium, Klonopin, those. So those work a little bit differently in our bodies. So when we're talking about naloxone and saving, we're really trying to think about those opioids and maybe a lot of with that new like fentanyl getting laced into our drug supply or prescription opioids as well. Can I give it to myself? The quick answer is no. Overdoses can happen really quickly. Fentanyl, it takes about 2 milligrams for an average person to have an overdose. So I've seen that kind of compared to two like flecks of salt. It's really small amount, and it can hit you fast. It could be seconds to minutes, and then you could be in a really, really critical state where you need to be reversed with naloxone. So short answer is no, you don't give it to yourself. You should be using with a friend. I actually did see an app that is out there too. It's called Brave. So if you are again attempting to use a medication on your own, this app has somebody who's experienced with either using drugs and signs and symptoms of overdose, so they could be there with you. So even though it's an app, it's virtual, but there is still a possible way to have somebody there, or just call your friend, right? Um, we just don't want to be alone, and because if you use alone, you could potentially die alone, and that's not something we want, and we want to prevent, right? Another tip to think about is don't use by yourself, right? So, and then use a small amount very slowly. You want to be able to stop it if something is not right. So just don't take a big dose all at once. And if you're with a group or two people at least, have one person take the medication at a time. We want to watch and wait before the next person uses. So we want to make sure everything's okay. And next question here I have are what are the side effects? So again, naloxone is a generally safe medication, um, but some individuals may experience some withdrawal symptoms, which can include what I listed there: confusion, sweating, vomiting, and irritability. The main thing is, this is also going to be dependent on how frequent the person is using and if they've built up a tolerance or dependence at this point. But I would say it is pretty fast acting as far as some of these withdrawal symptoms, which we will talk about here with some of our next questions. So one thing we always hear about, especially when I'm talking to somebody in the pharmacy, if they're just picking it up to be Good Samaritan to have on them, maybe they're going to a music festival and they want to have it on them just in case. Does naloxone make people combative? I'm saying no, but no, this is not 100%. People could still be agitated. There could be the outlier to the rule, but it is very rare for somebody to wake up from an overdose and be combative. Like I said, most people will be confused and disoriented after the administration of naloxone. I would also like to add, if you are using with friends, it's especially rare for somebody to be combative after it's been administered if they're with people they trust, right? I think if you are waking up to maybe some foreign faces, you might feel a little bit more agitated or kind of more alerted to being a little bit more defensive. But if you're with people you trust, I would not expect that reaction at all. And then, does naloxone cause precipitated withdrawal? So, yes is the answer here, but I would preface it with saying, we have to kind of assess where a patient's at. What is their tolerance and dependence to this medication? If they're building a tolerance and using higher levels to get that same high, and they're building a physical dependence where they need it just to stay normal, we're at a higher risk of having this precipitated withdrawal. If it's a one time, somebody's taking a dose, it's laced with fentanyl, they're going through this, we're not really going to have this precipitated withdrawal as much because we're not having that physical dependence. So that's something to think about. But again, we're kind of talking about with when we think about precipitated withdrawal, these symptoms tend to dissipate. They tend to go away after about 30 and 60 minutes. Again, that's also where we're talking about we need to go to the emergency department or have some care with us, because after this 30, 60 minutes, these withdrawal symptoms can start to dissipate, but then we might have those drugs in our system still that are putting us at risk of overdose again. And last here, can I get in trouble for administering naloxone? Short answer is no. Washington has a Good Samaritan law that provides protection. Basically, if you are immune to a lot of laws if you are seeking a good faith effort for medical help. So this includes drug possession. So it would include both somebody who is calling or helping the person who is overdosing, and it also includes the person who is under the influence at that moment. They will not be charged from drug possession at that point in time. I would say, even this covers too, say you didn't feel comfortable calling 911, but you want to drop a friend off at the ED, you are then immune to taking somebody to the emergency room, because again, you are making a good faith effort and helping them get medical care. But I would say this does not contribute to protecting you from any outstanding warrants, probations, parole violations. So if there are other issues, that could then be something that could be a problem, unfortunately. But as far as drug use or having drugs on you, you will not be charged for possession. And the last questions here, just regarding secondhand fentanyl exposure. So unfortunately, there's kind of some misinformation with this years ago. Kind of came through where saw with some police and people being really scared to handle or help people who are overdosing because they were scared of having to overdose themselves due to secondary exposure. Um, some credible sources, CDC, DEA kind of spread some things out to police officers that then kind of went out and around. And it was unfortunate, but we do have a little bit more scientific data now and some information about it. So hopefully this could dispel some myths or any questions people have. First one, can you overdose from secondhand smoke? So there have been no clinically confirmed overdoses. People who have breathed in the secondhand fentanyl smoke, the risks are very low. Not to say that they're, but I would not expect it to happen. Fentanyl concentrations in the bloodstream after somebody has been exposed to secondhand fentanyl smoke, the levels are extremely low or not detectable. So that's really good to know. Also to think about from my pharmacist point of view, fentanyl is fat soluble. So it likes to get into tissues like your brain, your liver, others, and it doesn't really want to hang out in the air and linger in the air. So it's good to know if it's being exhaled, it's not really at a high risk to yourself. And the second question is, can you overdose from touching fentanyl? Fentanyl does not easily absorb through your skin, so it's not something that you would really overdose from touching it. You can't overdose from touching fentanyl pills or powders. You can wear gloves to protect for normal protection, and if it does touch your skin, wash it off with just soap and water is all you need. You don't want to use any sort of alcohol-based hand sanitizer or anything like that. That could actually increase the absorption in your skin, and you might get higher levels, which would not be good. But just to put some ease into your mind, if you do get any on your skin, when we look at fentanyl that we use for transdermal patches, it takes 3 to 12 hours for it to get up to its level to start having effect in our body. Then it takes up to 35 hours for us to get the max peak in our body once we have it on our skin with a patch. So if we do have exposure to our skin, let's wash it off, take care. But no, it's not going to be an instantaneous reaction or anything, and you wouldn't really expect an overdose anyways. And with that, that's the end of the presentation. I'd like to thank so much for for coming, watching the presentation, listening, and then we'll field any questions that you have. I would add, I did put my email there, so if anybody has questions, feel free to reach out. I appreciate it.
Oh, wonderful. Thank you so much, Dr. Taniguchi. We do have a handful of questions, so let's dive right in. I'm going to start with one in the chat box, so don't forget about it. Does the Good Samaritan law also cover providers?
I would assume so. I don't know as far as like a provider in like a medical doctor. I don't, with the pharmacy laws, I'm more involved with that than the other side. But I would think with the Good Samaritan law and a doctor, you're trying to do no harm, you're trying to save somebody's life. I would think it would definitely cover that. But I can't give you the definitive yes or no.
All right, perfect. Thank you. Folks, if we find additional information on that exact question, we can go ahead and post it in the follow-up to the chat directly. All right, so let me go through the Q&A box questions. All right, so this individual says that I live in Texas, and our state program that offers and supplies free Narcan to individuals and organizations often runs out and can't keep up with demand. Do you have suggestions for getting free Narcan outside of this type of state program? Several grants restrict purchasing Narcan, so grants don't always fix the funding issue.
Yeah, I'm thinking once we get that over the counter in the market, it might be kind of solving the issue. I'm thinking some of the supply chains and manufacturers with the manufacturers, it's kind of altering the way they're supplying some of it. But I know it is a hot product. It's hard to keep on the shelves and keep up with the demand. As far as any advice, I would try to just follow up with other pharmacies, see if there's anybody around who might have some stockpile or have some on hand that they can help out with. Um, Unfortunately, I don't have much more than that. I'm hoping with the over the counter, we'll see kind of that start to ramp up and hit the market. And they try to at least help out with some of our supplies.
And I know I can't speak to the Texas landscape very well. I know in
Okay.
Washington there are quite a bit of like local coalitions, local health jurisdictions that do provide naloxone
Nice.
for free. All right, so let's move on to the next. Is there support for training in naloxone use and providing access to groups that serve vulnerable communities? Any specific ones you know of?
I don't know of any specific groups. I know some of those resources I put out there. I would say stopoverdose.org has a lot of good information, some help for information about it. The Washington State Department of Health has a whole opioid naloxone website that has a lot of links to a lot of good training. I would say I don't know about big groups, but if you had questions, me being a pharmacist, I'm going to, of course, advocate for that. But you could come by a pharmacy and ask the pharmacist some questions. They'll be more than happy to help you out and kind of walk you through any questions you had about administration or anything else.
All right, perfect. We have a question on what are the symptoms of an allergic reaction to naloxone? And do you know the percentage of people who are allergic to naloxone?
So as far as the allergic reaction, I don't know the percentage off the top of my head. It's been labeled as rare, so it's going to be less than 1%, I would assume, when we think about that, or around the 1% mark. But allergic reaction, depending on how we're administering it, or kind of depends on our sensitivity, right? So if we have an allergic reaction and it's anaphylactic, anaphylactic reactions are bad, where could have like swelling of our throat, difficulty breathing, could have we're having a really bad immune related reaction, so it's our body's like freaking out, and that's in a medical emergency on itself. So that would be a very bad situation if you are allergic to that. As far as other allergic reactions, could be mild. Maybe we're getting some swell if we're doing the nasal application, some swelling or some issues with the nasal application. Maybe some injection site reactions for doing the intramuscular or sub-Q. Yeah.
All right, and then how many doses can you administer for one episode? I believe they mean one,
One
episode of
overdose,
overdose.
kind
Yeah.
of, yeah. That's going to be really dependent on the dose that was administered or the dose that that person who's having the overdose symptoms. But you could give as many without really harming the patient. So I think it's a matter of really kind of looking and monitoring to see how their breathing's going, how they're reacting to the medication. Like we were mentioning, fentanyl is super potent, right? We're saying it's about 80, 100 times stronger than morphine, 50 times stronger than heroin. So it's harder for naloxone to work when it's a very potent med like that. So if we're doing like the nasal spray, we're assessing every 2 to 3 minutes, watching the breathing, and we want to administer that dose every 2 to 3 minutes. Alternate nostrils as many times as needed until that emergency medical is there, and they'll keep administering naloxone as needed as well.
Perfect.
So there
Now,
is like no cap. You're safe to keep using it. Just really focusing on patient care, make sure that they're breathing and staying alive.
perfect. My own clarifier on that. You just said to make sure you wait 2 to 3 minutes between doses, and you can keep chaining, providing you wait those 2 to 3 minutes. Why is it important to wait those 2 to 3 minutes rather than just front loading a bunch of doses all at once?
The main thing is we just wanted to make sure it's working. We give it time to work because when we're doing the nasal application, it needs to absorb through those sites and then get to the effect of where it's going to start. So basically, this is like a receptor in our body. Opioids are like this. Narcan comes in and pushes it out and then fills it in with itself. So we got to give it time to work and start using. You could front load it, but then it works so quickly that we want to make sure if we do need more, we have that extra dose available, especially with the kits that we only really have two. We're kind of going to be limited to those two. So we want to make sure that we're using that first one, testing the efficacy, make sure it's working. And then we want to kind of come in with that second one if we need it.
Perfect. Thank you. My mind also goes to what you were saying about precipitated withdrawal. And I imagine if we just front loaded and slammed, we would just slam that poor
Bring it right out.
patient
Yeah.
right into it right off the bat. And I imagine that has got to feel miserable. All right. Another question here. What is the youngest age you can administer Narcan?
I don't know the pediatric data. I can't answer that off to the top of my head. If you want to put that in for your email in the chat or give it to Alex, I will certainly could look that up and get it back to you. I apologize. I don't know that information.
No problem. And thank you for asking that question. Well, again, it's not going to go away once the session ends. So we'll do our follow up on the back end and go ahead and report.
I'm writing my notes down too, so I'll get them.
Perfect. All right. I'm going to refresh this again, see if we're going to get any other questions. Okay. Here's another one. What are your thoughts on the efficacy of Revive, considering it will be 3 milligrams, especially with the increasing fentanyl overdoses?
Yeah, very good question. Thank you. I was trying to look into that a little bit. It's hard couldn't find much information. I think once it's out there, we'll get a little bit more information, but it looked like the 3 milligram was trying to use more of a novel or a new delivery. So that way it's working a little differently in our body. So therefore they could use that lower dose with the same effect as the 4. So I think they were, that was their goal with that and how they were trying to get that approval done. So that way wasn't really a competitor with Narcan. It was its own new kind of delivery system.
All right, doing another refresh. Oh, perfect. Thank you, Amanda. I see you your info there. Thank you for adding that. Do another refresh. Sorry, guys, I got to keep refreshing because Huva does not seem to want to give me the questions as they come. All right, not seeing any new ones. Let me shift toward mine. I think the one I have left personally, I've been asking the speakers I've moderated today this question or a variation of it. So if folks just read the session description and didn't have time to actually watch the presentation, what is the one takeaway, bit of knowledge or action item you would like them to have coming from this?
My big one is carry naloxone. And how we had that question about stigma. I mean, I keep one with me at all times. This I ride public transit. I ride my bike around the city a lot, and I just want to have it on me. Even if I'm going on a bike ride, I carry it just so I know. So that's the big thing. We can't prevent or have make a bigger impact if we're not really trying to make a difference. So I think having that open conversation with people who are using and just know it's about their safety because we care about them would be my big thing. So to take carry naloxone and have that open conversation with people would be my two big takeaways.
All right, perfect. I'm going to do one final refresh, folks. So we'll see if there are any lingering questions or comments. Let's see, I'm getting a lot of thank yous in the chat box. That this has been a very informative session. So I will echo that. Thank you so much, Dr. Taniguchi. And all right, I think this is a good time to call it. So folks, keep an eye out on the chat box. If you've got additional questions, feel free to plop them in there. We'll be paying attention. Keep an eye out for the recording. We'll go ahead and post that as soon as we've got it available. And stay tuned for more. This is the end of our first day of this year's overdose awareness series. So thank you so much, Dr. Taniguchi, for wrapping up day one.
Thank you so much. It's been a pleasure.
Perfect. All right. Thanks so much. Take care, everybody.